Hello and welcome to Checking the Vitals, a podcast powered by SpecialtyCare. I'm Todd Schlosser, and today on another special COVID-19 episode, our guest is Tysharra Belfon, a PICC nurse on SpecialtyCare's surgical services team. In this episode, we discuss the role of a PICC nurse, how COVID-19 impacts this specialty, and what precautions are being taken at her hospital to keep frontline workers safe. Enjoy the conversation. So thank you so much for joining us. I really appreciate your time, and I realize that you're super busy with all that you're doing, so I really appreciate it. I really want to start off with, what exactly is a PICC nurse, and what do you guys do normally? What is like a normal job function for PICC nurses?
Okay, so basically a PICC line is a type of central catheter.
Mhm.
By saying central catheter, a PICC line is something that essentially goes from um, a larger vein in the arm and it threads into essentially your central circulation, which is your superior vena cava that sits on top of the heart. These catheters are actually very essential because they act and allow the same function as a traditional central line, which is usually placed in higher pressure vessels like your jugular, your subclavian, your femoral, which have a higher incidence of infection and blood clots, which could also be, pretty detrimental to a
Problematic, yeah.
patient. So the PICC line is like a nice little hybrid because it's inserted centrally into lower pressure vessels, which are your brachial, your basilic, your cephalic veins, and then we thread that catheter into the central vein. So that way we decrease infection, we decrease the risk of having something really detrimental happen to the patient. Not that there are always risks. However, the PICC
Sure.
lines are actually less invasive than a traditional central line, which makes them, super cool because we can still place, all types of medications, all types of pretty strong medicines that would not be tolerated in a traditional IV. We can still have the ability to give the patient, nutrition. We can give them pressors. We can give them all types of things without really compromising their health in essence of increased risk of infection and
Yeah.
blood. So we have the ability to put single 1 to 3 lumens into a
Oh,
patient
okay.
depending on what they need. And each of the lumens are their own entity. So even though they're connected together in one catheter, they all have separate exit points, which is what makes this PICC line so cool because we can place medications that are not compatible together um, inside of the same PICC line, and they will exit the body at different points without ever meeting.
Interesting. Okay.
Where we have 3 different access points. That is the brachial. We have 2 brachial veins. We have a basilic vein and we have a cephalic vein. And we usually typically choose that vein based on how good it looks. So we only choose the best looking veins, make sure they're juicy and they're
Right.
pliable. And we go
Juicy,
ahead
I'm
and
sure, is not the technical term, but yes, it makes it easy for me to
not
understand.
a technical term, but it makes it easy to understand.
Yeah.
We want a bigger vein because we never want to choose a small vein, because when choosing a small vein, you have to take into account of the surface that the catheter will take up. And again, we talked about earlier, blood clots. We don't want
Yeah.
to ever cause harm to a patient. We want to make sure that we're only benefiting them.
Right.
So by choosing a larger vein with a larger surface area, that can accommodate the catheter and still leave room for blood to circulate around the actual catheter
Yeah.
and prevent any type of blood clots. So this catheter essentially goes from a vein that we choose and it threads to the central location right on top of the heart, which is why we call it a peripherally inserted central line catheter.
Okay. So it's something that stays in the patient, right? It's not like someone who goes in there and draws blood like a phlebotomist. Like it stays in there, and it is for people who are, I would say, and correct me if I'm wrong, clearly, but I would say it's for people who are, in the hospital for a number of days, and they've got something going on that's going to be, it's going to take some days to get over, right? So they're going to need not maybe fluids, but medicine, sort of uh, over the course of that stay. Is it always the same like substance, like the same medicine that's going in the PICC line, or is it can it be a number of things?
So the cool thing about PICC lines is that it can be a number of things. It can be something as basic as hydration,
Oh,
and
like
it can be
fluids. Okay.
something. Yep, it can be something as complicated as total parental nutrition, which is
Oh, wow.
basically giving patients all of the electrolytes and the lipids and all of those things that our bodies need, but they're not able to actually consume them. So, and they have a high concentration of different proteins, different lipids, and it can also be something, it can be pressors. We use it a lot in the ICU because a pressor is something that when patients have essentially low blood pressure, we want to increase that blood pressure.
Right.
Essential medication. So a PICC line is basically for any medication that we cannot risk not getting to the patient.
Right.
So it's foolproof. We know that when we place it, we have a way of confirming placement that is right on top of the heart, and immediately within seconds it's whisked away into the central circulation, and it starts to work. So it can be also taken home. A lot of patients
Oh, wow.
actually take PICC lines home and they receive antibiotics. So it's a very long term, essentially it's something that's long term. So we usually have patients on a PICC line from 6 weeks to, it can be up to a year. I've seen patients maintain a PICC line.
Oh, wow. So they go home and sort of maintain it and self-medicate, I'd imagine, with
No, we have a
antibiotics?
nurse
Okay.
that is
Okay.
that's trained, that's gonna go out, because again, it's a central catheter, so
Yeah,
we
it
can't
scared me a little
risk
bit. Yeah.
anyone. Yeah, we can't risk anyone getting infected or
Right.
dislodging that. So we have a nurse that comes out on a daily basis that will
Okay.
come in and use the medications as if they were in the hospital.
Okay, so but you are in the hospital, and one of the
I
reasons we
am.
wanted to talk to you is because you are someone who is dealing directly with these COVID patients in a PIC nurse capacity. So let me, before we talk about exactly how your job has sort of changed, can I talk about how the hospital has changed since
Yeah.
COVID-19 has come to your area? And do you mind if I ask what city and state you're in?
Yes. So the hospital is in Aventura, Florida.
Okay,
That
so
is a part of Miami.
yeah, okay. So it's one of the areas that's been hit pretty hard. It's maybe not like a New York or New Jersey, but it is one of the higher areas, right? So you guys have seen probably quite a number of cases in your hospital. So how
Yeah.
has just the hospital changed since COVID has come to your area?
Well, the hospital is essentially, I mean, like everything in our day-to-day life is totally a 360 from what we're used to.
I'm sure.
So in the hospital, we're used to having visitors, we're used to having family, we're used to having that engagement, that comfort for the patients.
Yeah.
And that's totally changed. Basically it's just essentially what the patient's there for, and there's no visitors. We have everyone is pretty much on high alert, unfortunately, because we have so many cases, and like you mentioned, it's not as bad as in New York, but
Yeah.
it is very, we have substantial cases.
Yeah.
Our ICU, we have one whole wing of ICU patients
Oh, wow.
that are COVID-19. We have 2 floors dedicated, so with the ability of 40 patients each floor. So if you do the numbers, that's about 100 positive patients
Wow.
in
Okay.
a day, with others pending. So
Yeah.
it's been a very nerve-wracking situation for both the patients, the nurses, the doctors, and everyone.
But you guys haven't run out of space for the people who need care yet?
No, we have
Okay.
not. Thank God.
That's
Yeah.
great. Yeah. Okay. So you've clearly seen quite a number of cases. So like in the hospital, they've isolated them off into, it sounds like, two separate floors of their own wing. Is that what you said?
So we have 2 separate floors that are dedicated for COVID-19 patients, which they
Hmm.
are isolated essentially from other patients.
Right.
And then we have an isolated ICU that are for
Okay.
the critically ill patients that
Okay.
need to be on ventilators. And
Right. So yeah, ventilators or ECMO or things like that, I'd imagine, because those are really the last like lines of defense against it, right? Because
yeah.
either your heart can't handle it or your lungs can't handle it, and normally it's the lungs, so it's a ventilator or ECMO who's sort of
Mhm.
helping out with that, which is it's just amazing that people are able to do this work. So, and you're one of the people who go into the infected area. And I
Yeah.
understand that a lot of people in the hospital, they work in the hospital, but they may be in like an OBGYN and they're not really, related in COVID, but still have to go into the hospital to do their job because it's essential. People are going to be giving birth during this time.
Absolutely.
So those people are staying out of those areas, right? You are
Mhm.
someone who needs to go into those areas. So what is it like going into those areas every day? Like, what is the process? Because I'd imagine with things like PPE requirements and
Mhm.
I'd imagine there are somewhat of checkpoints. Maybe that's not the right verbiage, but security on some level. So what is that
Mhm.
process like?
Okay, so when it comes to ICU, because we typically spend a lot of time in the ICU, and we do go to the floors.
Mhm.
But in the ICU, there is, like you said, a checkpoint, I would say, where you have to be badged in and you have to have access to those areas. So
Yeah,
we try to limit the amount of people that, if you don't have a reason to be over there, we of course want to protect you at all costs.
yeah,
Um, so prior to, typically, I'll just run you through if we have a patient. So at the
sure,
beginning of our shift, of course, we always disinfect. That's always been something that we're really big on because, again,
yeah,
we're using catheters and we're using really invasive things. So we always disinfect. But now we're like really suited up. So we
yeah,
have you pretty much, I call it like my beekeeper suit, because we have face shields, I wear goggles, we
yeah.
have N95 respirators. We usually put a mask on top of that, as well as head covering.
You have the N95 mask and then just a regular surgical mask on top of
Yes,
that, and then you
yes.
have goggles protecting your eyes, right?
Mhm.
Are the goggles in place of a shield? In a lot of photos, you see like a whole shield in front of someone's face. Do you
So
have?
I use both.
Oh,
So we
okay.
do, yeah, we use
Wow.
both. We usually, typically with our procedures, we like to have shields on because there can be splashes of blood, fluids,
Yeah.
and everything. So we will always use goggles. However, with the COVID patients, we also have shields that were actually provided to us by Specialty Care.
Oh, okay.
They ordered us special shields as part of our complete PPE
Yeah.
because it is a respiratory disease.
Mhm.
So meaning, the virus can be carried in particles. So having only goggles would still expose your skin, your face,
Yeah.
to being, an area that can, essentially contaminate. So on top of our goggles, we usually do have a shield on to keep us from, having any splatters or anything that actually gets onto our skin while we're doing procedures. We also use gowns when we're with these patients, of course, gowns and gloves prior to entering the room, especially in the ICU, because they are vented, and that unfortunately is a way that the particles can be transferred, you
Sure.
know, at a higher rate than just breathing on their own independently.
So you sort of beekeeper suit up, as you mentioned, and then I'd imagine after you do that, that's when you walk in, right?
Yes.
So I'd imagine there's just a bunch of patients there, and you have. Well, walk me through sort of what it's like to be a PICC nurse walking into an ICU. Like, do you have people you need to get a PICC line for, or are you just maintaining other PICC lines that you've either set or a coworker has set? So, like, what is the job function once you're in the ICU?
So our job function is typically to insert catheters.
Right.
The nurses are pretty good at maintaining, so we don't have to troubleshoot very much. If
Okay.
we do, it's very minimum. It's a very small percentage of our day. So our main function is to provide central or IV access for those patients. So typically we have orders that come in for the day. A physician will put an order for us. We
Yeah.
will go through, and as we do with any patient, we make sure that the patient is a candidate, because we of course don't want to cause any harm to a patient,
Yeah.
even though, because not everything is for everyone. So even though it's a great access tool, it may not actually be in the best interest of the patient. So we always work that patient up to make sure that they're a candidate, make sure that they're hemodynamically stable enough to endure the procedure itself,
Yeah.
because it is essentially a procedure. It's about 30 minutes long.
Oh wow.
And yeah, so once we do that, we maintain communication with the nurse so that we have consent prior to coming, because it is an invasive procedure. We have to make sure that either the patient or the patient's proxy consents to having this procedure. So by the time that we reach the ICU or whatever area that we're going to be going into, we've already made sure that this patient is appropriate. We're consented. So that essentially, helps us out, because we're not wasting unnecessary time
Sure.
being exposed. So typically when we get down, we badge in. The charge nurses are really good about having any equipment that we need for each patient. Of course, we need a gown, because we can't, we're walking across the hospital, we're going to different areas, so we're not going to be in the same gown the whole day. passing people in the halls.
Yeah,
So we
I actually wondered about that. So like when you
Mhm.
leave the ICU to, I don't know, go to
Mhm.
lunch or maybe take a break, or
Yeah.
I don't even know if you guys are getting breaks right now, but to leave the area, they are trying to keep people who are not, in the job function that is, servicing COVID patients sort of away from that area. So I'd imagine either they send you to your own like break or lunch room, or you
Mhm.
completely unsuit and then resuit in something that's more friendly to the regular hospital environment. Is that what's going on?
Yeah, so basically we're always in our uniform. So the
Yeah.
only thing that we put on is our protective gown, which is we use that for any contact patients
Okay.
because that protects our actual body, our uniform, our bodies from being infected or carrying any type of bacteria on our person.
Right.
When it's time for lunch, if we ever get a lunch, because right now it's like crazy. So
Yeah.
we have our own office, so we are
Okay.
isolated. We're not on a nursing unit. So when
Okay.
it's time for us to leave the wing, we usually will take off our gown. We'll take off our gloves, of course. We never
Yeah.
want to contaminate ever. We'll take those items off, and the only thing that we'll typically keep on is our mask because right now, as you know, that's our protection from. Unfortunately, it sounds crazy, but from everyone else because you never know who may be infected. So the
Yeah.
whole hospital, all the nurses we're all wearing masks at all times unless we are in our designated eating area in which, we go back to our office and we're isolated. We're by ourselves and then we'll take our mask off and take everything off to eat. And then
Yeah.
we
Put it
resume
back on. Yeah.
put it right back on. But as far as the gowns and everything, we always take those off. We of course never gloves are never taken. Gloves are taken off and changed multiple times. So
I'm
within
sure.
one
Yeah.
week, we change our gloves multiple times.
Yeah.
And that protects not only ourselves, but that protects anyone that we're going to come in contact with.
Yeah. So when you're in the ICU and you're having to change gloves, do you have to step out of the ICU to change gloves? Because I'd imagine
Um,
you're doing multiple, pick lines, in the same stint in the ICU, right?
yeah. So our patients in ICU, there's no shared. So all patients are in private rooms. They're all in their own
Oh,
rooms.
okay.
Yeah,
Okay.
they're all private. We haven't gotten to that point where I saw,
That's
they
great. Yeah.
start to build like stadiums and stuff, but
Yeah.
no, all patients are isolated. They're in
Okay.
private rooms. Even on the floors, they are not in grouped together.
Okay.
So if we need, we have a little ultrasound. So that's how we do our procedures. It's via an ultrasound.
Okay.
And what we do is we have that ultrasound actually stocked with our supplies. So for a PICC line, we use sterile gloves at all times.
Yeah.
So we have multiple packets of sterile gloves. We have multiple packets of any items that we need so that we're not going in and out of a room, whether it's COVID or not.
Right.
We never want to introduce any outside contaminants into a
Sure.
sterile procedure. It's
Yeah.
like we treat it like an OR. That's
Yeah.
what our procedures are. We treat it like an OR. So we don't have to ever go outside. Once we're in, we're very meticulous about making sure all our T's are crossed and our I's are dotted
Yeah.
before we go into any procedure. Just as if you were in an OR, the doctor's not going to be like, "Hold on, I'll be right
Yeah.
back. Let me grab some gloves." He has
Yeah.
everything
Right.
in place. So
Absolutely.
of course, before we, go in, we're donned in all of our PPE. And
Uh-huh.
once the procedure has concluded, then we will take off our first layer, which would be our gloves because we've actually had contact with that patient.
Yeah.
And typically we'll have double gloves. So we'll have clean gloves underneath.
Ah,
That way
that
we're
makes
able
sense.
to take our equipment out with those clean gloves and disinfect
Okay.
without, dragging our equipment with the same dirty gloves.
Right.
So
Yeah, I
yeah,
wondered about that. Okay. That makes sense. So you're sort of going in between all these ICU isolated rooms for each COVID patient, or at least the ones you need to put a PICC line on. How long is a typical stay? Is that something that you deal with or you see in your day-to-day routine? Like how long a typical stay is for someone who goes into the ICU with COVID?
For us, we don't typically deal with them on a length of stay.
Right.
We're seeing multiple patients. We see from about 6 to 10 patients in a day.
Oh, wow.
Um, yeah, for catheters. So we unfortunately we don't have that information about how long it takes. But typically with any length of stay, it's basically patient to patient because
Yeah.
some patients can really come in and they just really need hydration, they need fluid, they need a little bit of support, and then their immune system kicks in and they're transferred out to a step down unit. And then you have
Okay.
other patients with multiple comorbidities that will need
Yeah.
to be on a ventilator and need, other support long term.
Yeah.
So it varies patient to patient.
That makes sense, I guess, especially if you factor in the different kinds of comorbidities. I'd imagine there's a different length of stay for all of them, and that
Yeah.
makes sense. I know a lot of people who work in healthcare are working more than they typically do. They're, dealing with more negative outcomes than they normally deal with. What is your hospital or even the community around your hospital doing to sort of help keep up morale of the frontline workers?
So you're right. It is a very trying time for not only healthcare workers, but it's a very, trying time for us all. We're all
Yeah.
going through different things, whether it be financially, whether it be, actually socially. So I feel that, the morale is usually kept up pretty nice, because right now it's something nice that's going on in the community that before, we never really saw. I think it's World Health Organization that says 2020 is the year of the nurses, and
Yeah.
we didn't imagine it would be like year of the nurses like this, but it's
Yeah.
pretty cool. And in the community, there's a lot of things that actually matter, and maybe small as Starbucks giving us a cup of coffee, or
Yeah.
restaurants bringing in lunch, and really trying to show their appreciation. We hear a lot outside. We'll hear like the cars honking, and the paramedics putting their alarms on, which is super cool and important to really keep you in good spirits during this time when it
Yeah.
could be a devastating time.
I'd imagine it could be sort of a bleak time, maybe not personally, but sort of the feeling across the country because of this is sort of bleak and down. And it's great to see
Yeah.
sort of communities coming together to support those who are on the front lines. Like you mentioned, Specialty Care sending you guys face shields because they want to make sure that you're absolutely protected, because if people on the front lines get it, who's gonna do those jobs
And,
that people can't do, So that makes sense to me, but it's awesome. And I just want to thank you so much, both for doing the job that you do every day, but also taking the time to talk to us today. I appreciate it.
absolutely, anytime. It was great to share that.